Hello, my name is Lisa Rodovich, and I'm a Doctor of Nursing practice student at East Carolina University. Today, I will be presenting a policy analysis on the Improving Veterans Access to Quality Care Act. First, I would like to provide some information about why nurse practitioners as professionals should put time and effort into being politically active to help shape healthcare through policy. As professionals, nurse practitioners advocate for their role and profession as well as the improvement of social and healthcare policies on behalf of individuals. When illness interferes with a patient's independence to make choices, nurse practitioners often advocate on their patients' behalf for healthcare resources. Unfortunately, the value and impact of nurse practitioner delivered healthcare services are often hidden. More and more, our healthcare system depends on nurse practitioners. During this era of healthcare reform, the impact of nurse practitioner delivered healthcare on quality, safety, and costs must be visible. Advocacy requires commitment and presence. Nurse practitioners must become politically engaged to help shape the changes needed to highlight the contribution of nurse practitioners in the delivery of quality, safe, and cost effective services. Limitations on nurse practitioner scope of practice and healthcare delivery negatively impacts communities by not allowing services to be provided by highly educated and trained nurse practitioners with restricted practice acts. The problem statement for this policy analysis is: currently, veterans in the United States are experiencing postponed or canceled surgeries due to lack of anesthesia providers in the Veterans Health Administration. Would granting full practice authority to CRNAs as part of the Veterans Access to Quality Care Act decrease surgical wait times for U.S. veterans? Healthcare is expensive and is one of the most regulated industries in the world. There is currently a shortage of primary care providers due to population growth and an increased number of insured consumers. The Health Resources and Services Administration has identified roughly 5,700 geographic areas containing 55 million residents as being primary care health professional shortage areas. The Department of Veterans Affairs was designated as a high-risk area in 2015, and it continues to be an area of concern regarding the VA's ability to ensure its resources are being used cost-effectively and efficiently. Concern still surrounds the VA's ability to improve veterans' timely access to health care and to ensure the quality and safety of that care. The VA is one of the largest healthcare delivery systems in the nation and has faced a growing demand by veterans for its health services. This may be due, in part, to service members returning from U.S. military operations in the Middle East and to the needs of an aging veteran population. These trends are expected to continue. The total number of veteran enrollees in the VA's healthcare system rose from 7.9 million to almost 9 million between 2006 and 2016. Over that same time period, the VHA's total budgetary resources have increased substantially from 37.8 billion in 2006 to 91.2 billion in 2016. Despite increases in the VA's budget and the number of medical appointments, there have been numerous reports of VA facilities failing to provide timely health care. In some cases, the delays in care have reportedly resulted in harm to veterans. An affected veteran included one who traveled across 2 states to reach the medical center only to find his procedure had been canceled. Horror stories about access to care issues within the VA system, many related to anesthesia delays, are popping up across the country on an almost daily basis. The Veterans Health Administration finalized a rule that would allow certain APRNs working in the VHA to practice to the full extent of their training, education, and certification. However, the ruling excluded CRNAs. Granting full practice authority to CRNAs would be consistent with current healthcare delivery models for our nation's active duty service members. Doing so would reduce wait times for primary and surgical care, ensure patient safety, and give veterans access to the timely, high quality care they deserve. Reports out of just one VA medical center in Denver, Colorado, say that since early August, as many as 90 veterans have had to go without needed surgical procedures due to lack of anesthesia providers. At the beginning of 2017, the VA claimed there wasn't an access to anesthesia care problem in VHA facilities, despite substantial evidence to the contrary. A congressionally mandated independent assessment of VHA facilities had confirmed that due to lack of anesthesia support, veterans routinely experience delays for healthcare services such as cardiovascular surgery, colonoscopies, and procedures requiring anesthesia outside of the operating room. The VA dismissed this evidence, succumbing to intense political pressure from physician anesthesiologists. As a result, the VA reversed its own proposal to grant CRNAs full practice authority, which would have ensured our veterans had increased access to surgery and other procedures requiring anesthesia services. This slide discusses the key stakeholders affected by this policy. Obviously, the veterans make up the focus of this policy. Veterans want, require, and deserve timely, quality health care. Delays due to inadequate numbers of providers is unacceptable. The Veterans Health Administration most definitely is a stakeholder, as they have been under fire for quite some time over delays in care, poor quality of care, and access to care issues. CRNAs are fully qualified to provide care independently. As a group, they want to be able to provide anesthesia services for the veterans to improve their ability to receive necessary surgical procedures in a timely fashion. The VA does not require CRNAs to be supervised by an anesthesiologist, nor does the federal government, state governments, or the military service branches. Anesthesiologists claim to be concerned about patient safety issues if CRNAs are allowed to practice without their supervision. However, numerous studies have shown that there is no difference in patient outcomes if a CRNA or an anesthesiologist are at the head of the table. There are many key factors surrounding this policy. Is this a political issue? Yes, and it is most definitely controversial. The physician anesthesiologists are fighting this issue because they feel the act of allowing CRNAs to select, order, and administer anesthesia drugs would unwisely loosen supervision to the point of endangering patient safety. However, many hospitals across the country operate with no anesthesiologist even on staff, and those roles are performed safely and effectively by CRNAs already without negative effects to patient safety. In fact, of the numerous studies that have examined the issue of nurses administering anesthesia, not one has found a reduction in patient outcomes. Many proponents of the policy argue that anesthesiologist opposition is merely due to protectionism, adding that some physicians earn up to $60,000 a year in passive income by supervising CRNAs. This policy does not change the scope of practice for CRNAs, it would simply remove outdated and superfluous physician supervision requirements. Who is affected by this problem? The veterans are most affected by this policy. They are having to wait too long for surgery, often ending up rescheduled or canceled, and are suffering the effects of not receiving surgery that they may desperately need. Often they don't have any other options with their health care. Economically, the VHA is wasting a great deal of financial resources that it simply cannot afford to waste, such as the 38 contracts with outside anesthesia providers at a cost of more than $100 million to taxpayers. This is clear evidence that available internal resources are not being used to their full advantage. Using the existing CRNA workforce in the VHA to its full practice authority would increase patient access to care without additional funding. In fact, it wouldn't cost the VA, federal government, or U.S. citizens one additional tax dollar to support. Is this a practical issue? It is very realistic to believe that this problem could be solved. Reversing the VHA's decision to exclude CRNAs from full practice authority would immediately reduce wait times for veterans who need surgery and improve quality of care to those veterans. What are the quality of care issues? Without a doubt, solving this problem would immediately address quality of care and access to care issues that the veterans are having regarding surgical procedures. CRNAs do not require supervision by the VA. By utilizing every single anesthesia provider rather than having an anesthesiologist sitting around watching while the anesthetist perform the anesthetic, the VA could increase opportunities for veterans to receive care by nearly 80%. There are three options I have identified related to solving this policy issue. Option 1. The reason given for the nearly 100 canceled and postponed procedures in Denver was a shortage of anesthesiologists and CRNAs. However, the real culprit had nothing to do with a provider shortage, especially not an anesthesiologist shortage. The Denver facility and many other VA facilities across the country use a 1-to-1 or 2-to-1 anesthesia delivery model with one or two CRNAs to one anesthesiologist. The CRNAs provide the hands on patient care, and the anesthesiologists are available to provide a second set of hands or eyes as needed, rather than providing actual hands on care. In Denver, if all of the 18 anesthesia providers working there regularly provided hands on anesthesia care to the veterans, rather than just the 10 who are CRNAs, the facility would increase opportunities for veterans to receive care by nearly 80%. Option 2. The solution to anesthesia related surgical delays in the VHA facilities is obvious. Both CRNAs and anesthesiologists need to be providing anesthesia to patients. The VA does not require CRNAs to be supervised by an anesthesiologist, nor does the federal government, state governments, or the military service branches. Furthermore, all anesthesia research studies done since 2000 confirm that CRNAs and anesthesiologists are equally safe providers, so it's not a safety issue. It is simply a waste of human and budgetary resources to not require anesthesiologists and CRNAs to both be sole anesthesia providers for different cases taking place simultaneously. And option 3. In January of 2017, the VA passed on an important opportunity to improve access to anesthesia care for military veterans, for which our veterans have been paying the price ever since. The VA granted full practice authority to all APRN specialties except CRNAs. Although the VA had initially included CRNAs in the full practice authority rule, they were ultimately excluded. The decision prevents VA CRNAs and anesthesiologists from being used to the full extent of their education, training, and licensure, and ensures that veterans would not have increased access to surgical or other procedures requiring anesthesia care. By changing that decision and granting full practice authority to CRNAs, the VA would make full use of more than 900 CRNAs practicing in VHA facilities, ensuring our nation's veterans have access to essential surgical, emergency, obstetric, and pain management healthcare services without needless delays or having to travel long distances for care. Although there may be more than one way to solve this policy issue, my recommendation is to grant full practice authority and scope of practice to CRNAs in the VA system. Granting CRNAs full practice authority would go a long way towards solving the VHA's access to care problem, which data show is only going to worsen. The VA's own enrollee healthcare projection model forecasts a 19% increase in demand for VA healthcare services nationally from 2014 to 2019 due to a projected 5.1 increase in enrollment and the aging of enrollees. CRNAs are highly educated APRNs who deliver anesthesia to patients in exactly the same ways for the same types of complex procedures, for the same severity of patient cases, and just as safely as physician anesthesiologists. CRNAs are well prepared to respond appropriately in emergency situations and already do so in combat areas for the Army, Navy, and Air Force and in combat support hospitals. The VA could make full use of more than 900 CRNAs already practicing in VHA facilities, ensuring our nation's veterans have access to essential healthcare services without needless delays or having to travel long distances for care. Granting full practice authority to CRNAs would also align VA policy with current U.S. Department of Defense policy that does allow CRNAs to work as full practice providers in all other military service branches. The VA is the last federal health agency to restrict CRNAs from practicing to their full practice authority. If autonomous CRNA practice is appropriate for active duty military personnel, it is also appropriate for military veterans. Nurses first provided anesthesia while caring for wounded soldiers on the battlefields of the American Civil War more than 150 years ago. CRNAs administer approximately 43 million anesthetics to patients in the United States each year and are the primary providers of anesthesia care in rural America. In some states, CRNAs are the sole anesthesia professionals in nearly 100% of rural hospitals. Utilizing the existing CRNA workforce in the VHA to its full practice authority would increase patient access to care without additional funding. To quote former Senator Bob Dole, this all hands on deck approach more appropriately engages existing resources, supporting a team centric rather than a physician centric approach, and won't cost the VA, the federal government, or U.S. citizens one additional tax dollar to support. This final slide lists the references used throughout this presentation. Thank you so much for taking the time to listen.